Hi guys, I'm gonna do a rapid review of step 2 CK USMLE. Sorry about my English, it's not the best, so I'm gonna try to do my best. Let's see, this is for to review later. So when I'm going to the gym or if I'm driving, so I like to go driving and hearing myself, like what I say. Whatever I say, whatever I read, I would like to go to keep, in this case, cardiovascular. Sorry for the shaking and everything. This is informal. I just want to be use the time meal driving, meantime driving, or meantime if I'm in the gym or something. Okay, so classic electrocardiogram finding an atrial flutter is sawtooth P waves. So in an EKG we can see P waves. P waves in form of sawtooth. This is a classic finding in atrial flutter. Definition of unstable angina is an angina that is new or worsening with no elevator of troponin levels. So troponin levels are normal. That's a unstable angina. Unstable angina. An angina that is new or worsening with no elevation of troponin levels. Antihypertensive for diabetic patients with proteinuria. Antihypertensive medication for diabetic patients with proteinuria is angiotensin converting enzyme inhibitor, angiotensin receptor blocker. So antihypertensive for diabetic patients with proteinuria. So we got angiotensin converting enzyme inhibitor, angiotensin receptor blocker. That's there's an acronym, but anyway. Angiotensin converting enzyme inhibitor, angiotensin receptor blocker. That's for patients with proteinuria, con problemas renales, with renal kidney disease. Triad of the Beck triad for cardiac tamponade is hypotension, the distant heart sound, and jugular vein distension. So in the neck, the jugular vein is huge, it's look big, and distant heart sound, they're like they're smooth, you can hear very well, and hypotension. That's a triad of Beck triad for cardiac tamponade. Drug that slowed heart rate. Beta blockers, I think so. Yeah, beta blockers, calcium channel blockers, digital amiodarone. Digoxin, and amiodarone. Those are drugs that lower heart rate. Okay. So hypercholesterolemia treatment that lead to flushing and pruritus. Okay, hypercholesterolemia treatment that lead to flushing and pruritus. Flushing, like your face gets red and plenty of flushing red face. That's a burst of niacin. Hypercholesterolemia treatment that lead to flushing and pruritus. Pruritus is like a itching. Niacin. Okay. So let's keep going. Murmur is like a sound in your heart. Murmur. Hypertrophic obstructive cardiomyopathy. So hypertrophic obstructive cardiomyopathy. That's it sounds like a systemic ejection murmur heard along lateral sternal border that raise with a lower preload valvular maneuver. So let me see if I can understand that. Systolic ejection murmur here along lateral sternal border that increase with the diminution of preload. valvular maneuver. Systolic ejection movement heard. Okay, it is a systolic ejection movement you can hear along with the lateral sternal border. Lateral sternal border. I'm assuming right side or left side. That happened with those guys who do sports and they suddenly fall and they feel because they have like the muscles so strong, so big in your heart. That's hypertrophic obstructive cardiomyopathy. That the wall of the ventricular of the wall of the interventricular septum is too big that close the in this case on the left side is too big that stop the blood from coming out of the left ventricle, so you can have syncope and things like that. So the murmur is a systolic ejection murmur here along lateral sternal border that increase with a preload. Okay, that murmur increase when you have a lower preload. That means if you have less blood going into the left ventricle, the muscles gonna be more hard to push out of the way. That's explanation. Yeah, if you don't have a lot of blood coming into your left ventricle, so the muscles is gonna block the way out of the blood. So if you got more blood coming into that ventricle, that do more pressure to the wall and push it out of the way, so the blood come out easily. Yeah, that's what's explained here. Okay, so murmur aortic insufficiency. Aortic insufficiency. Aortic insufficiency is like the blood coming back to the heart. When you do systolic, when you do the push the blood coming back to the heart. That's aortic insufficiency. So in this case, Austin Flint's murmur, diastolic decrescendo, low pitch blowing murmur that is best heard sitting up. Increase with increased afterload, hand grip maneuver. Okay. Austin Flint's murmur, diastolic decrescendo, low pitch blowing murmur that is best heard sitting up. Okay, so when they say diastolic, that means when the heart is relaxing, when the ventricles are relaxing, it's supposed to all blood come out of the ventricles. So when you relax the ventricles, they're not supposed to get filled again from the aorta. So they get filled again from the aorta. That's why it's decrescent. Decrescent means like going from big to slow, like a going from a big to a little tiny slow noise. Decrescending, low pitch. It's better here sitting because when you're standing, your blood pressure drop a little bit. So sitting, the blood pressure keep when you sitting, your whole heart is doing some kind of pressure to your heart to squeeze back the blood to the heart. When you're standing, it's more hard for your body to squeeze the blood back to the heart. So that's why when it's better here when you're standing up. When you're setting up, best heart setting up. It's confusing because setting up, best here setting up. When you stand up, they mean so increase with the afterload, increase afterload. Hand grip maneuver. Could you please somebody explain me that? But yeah, I got a little idea. Aortic insufficiency. So murmur. Oh my god, this is going too slow. It's supposed to be faster because when you're driving and things like that. So murmur, aortic stenosis. Murmur, aortic stenosis is like a systolic crescendo decrescendo murmur that radiates to the neck. It increases with a preload, squatting maneuver, squatting when you te aplata, when you said like a squat. Systolic crescendo decrescendo, like a the systolic crescendo decrescendo, like it's going bigger and then so big and then slowing again, like it. This is systolic crescendo decrescendo murmur that radiates to the neck, so you can feel it in your neck. This is aortic stenosis. Something that I remember, and when an aortic insufficiency, you can have like something called like the hammer hit, something like that, because the aorta they squeeze the blood, but then the blood come back, and it's like some kind of sensation like a hammer hit or something like that. You have to find that. So next one, aortic stenosis. We just say that. Murmur, mitral regurgitation. That mitral regurgitation. What kind of murmur is that one? Let's see. Somebody think before reading. Mitral regurgitation is like when the ventricle squeeze, and they relax again. The blood come. No, when the ventricle squeeze, the blood is not supposed to go back to the auricula, but in this case they go back to the auricula. That's a mitral regurgitation. So it's a systolic. It's a systolic murmur. Systolic murmur that radiates to the axilla. Increase with the afterload, hand grip maneuver. Yeah, because if you have afterload, if you have more blood's coming back. More blood squeezed back. Remember, there's some kind of mnemonic, like the right side heart murmur increase with this, and the left side murmur increase with that. You have to learn that. Go to check that, guys. So treatment for atrial fibrillation and atrial flutter. The treatment is unstable cardioversion. If the patient is unstable, you can do cardioversion. That's electronic cardioversion. If the patient is stable or chronic, you can control the rate with beta blockers on CCV. What's CCV? CCV is how to find out what is CCV is. I don't know. Oh my god, CCVs. What is CCVs? Calcium blockers. Yeah, I think it's calcium blockers. So if a patient is unstable, you have to do cardioversion. There's some kind of cardioversion called cardioversion synchronized. In this case, you shock the patient with a joules, starting with 150 joules, and you shock the patient, but you have to shock the patient in synchronize. You have to put him in sleep. If it's possible, you can intubate him, and then do a shock cardioversion. And if the patient's stable or chronic, just do the control rate, mean lower their heart rate with beta blockers or cardio channel blockers. So treatment for ventricular fibrillation. Is immediate defibrillation. That's the same. You have to shock the patient with a cardioversion machine. Defibrillation machine. Cardioversion is different from defibrillation. Learn that, guys. Cardioversion is different from defibrillation. Defibrillation is shock the patient with electricity. Cardioversion is shock the patient with electricity, but synchronize. That means that you're gonna throw the electricity, you're gonna shock the patient specifically in one part of this heart circle, in one part of the heart cycle or cycle. You don't just shock the patient in any moment. You just have to shock the patient synchronize with the heart. So the machine can sense the heart with the leads, can know where is exactly the heart, what part of what moment of the cardiac cycle is the heart, and they shock exactly in one point. I think it's in the atrial, with the electricity in atrial. So that's the difference in cardioversion and cardio defibrillation. One is synchronized, the other one is just shock. So Dressler syndrome that happened when the patient have a myocardial infarct 2 or 4 weeks later. So it's an autoimmune reaction with fever, pericarditis, and elevation of the inflammatory systemic response, occurring in 2 or 4 weeks after a myocardial infarct. So Dressler syndrome. Remember, Dressler syndrome. When you dress, you have to put your 4 extremities in your clothes, and so when you if you need to get dressed very nice for the occasion, you need to put your 4 extremities that are gonna remind you 4 weeks after a myocardial infarct. Okay, so Dressler syndrome. So IV drugs used with jugular vein distension and holosystolic murmur at the left sternal border. Treatment. What is that? Let's see. IV drugs used with jugular vein distension and a holosystolic murmur at the left sternal border. Let's think. Left sternal, right, left sternal border, aortic, pulmonary, mitral. So it's mitral. It's a mitral, valvula mitral, holosystolic murmur, holosystolic. I think that's a stenosis of the mitral. Treatment, I don't know. Could be surgery. Let's see. Treat existing heart failure and replace the tricuspid valve. Tricuspid? Oh, we're talking about tricuspid. I thought we was talking about... Yeah, we're talking about tricuspid. Remember, the tricuspid valve is the more often damaged in patients with IV drugs because, the blood coming from the skin, you get stuck on the vein, and then the infection or whatever bacteria get into the brain, go straight to the right atrium, and then from the right atrium go to the right ventricle. So going through the tricuspid valve. So that's why this is the more often get infected and produce heart failure because infectious endocarditis. IV drugs used with the JVD, that's mean jugular vein distension, because the tricuspid valve is damaged, and then the blood don't get very well to the right ventricle, so you got distension of the jugular veins. That's why you can have a stenosis of the tricuspid valve. So treatment is a existing heart failure. Treat existing heart failure because the patient is going to get at this heart failure, and replace the tricuspid valve. Nowadays they can put like a catheter inside the heart and try to squeeze some kind of like it open to force the valve to open, to break all the connection that the infection did. So diagnostic test for hypertrophic cardiomyopathy. Diagnostic test for hypertrophic cardiomyopathy. I think hypertrophic cardiomyopathy, echocardiogram is good. Echocardiogram showing the thickening of the left ventricular wall and the outflow obstruction. Yeah, they can measure the how much blood coming out in a minute, so that can give you the ejection fraction. It's perfect with that. Diagnostic test for hypertrophic cardiomyopathy is echocardiogram. So pulsus paradoxus. Pulsus paradoxus is I don't know. Let's read it. It is a diminution, reduction in the systolic blood pressure of measure of 10 milligram of mercurial with the inspiration. See in cardiogenic tamponade. Pulsus paradoxus. I think pulsus paradoxus is like when the pulsus is weak or something like that. But anyway, the description they give is a diminution of the systolic blood pressure. Systolic blood pressure, not the diastolic. The diastolic is 80 and systolic is let's say 17, 80 or 90, 80. Blood pressure 90, 80. Diminution of systolic blood pressure of more than 10 with inspiration. With inspiration. So when the patient have a big inspiration, okay, that happened in cardiac tamponade. Okay, yeah, because the heart is it can expand. It cannot expand very well because it got blood around the heart. If you get a big inspiration, you put more pressure on the heart. You put in more pressure on the heart. When you take a deep breath, your lungs get full of air, doing pressure over the heart. So if over that the heart has that like a tamponade, it'll have like it's swimming on blood. You put in more pressure to the heart, so that's why the blood pressure is lower. That produces a pulsus paradoxus. Okay. Classic EKG finding in pericarditis. Classic EKG finding in pericarditis is low voltage, diffuse ST segment elevation. Low voltage and diffuse ST segment elevation. Yeah, you have ST segment elevation in all the EKG. That's pericarditis. Eighth surgical correctable cause of hypertension. Eighth surgically correctable cause of hypertension. Let's see. Renal artery stenosis, coarctation of the aorta, pheochromocytoma, Cone syndrome, Cushing syndrome, unilateral renal parenchymal disease, hipertiroidism, and hiperparathyroidism. Todas esas son causas de surgically correctable cause of hypertension. Surgical correctable cause of hypertension. Okay, that's 8 causes of hypertension that can be fixed with surgery. Renal artery stenosis, coarctation of the aorta, pheochromocytoma, Cone syndrome, Cushing syndrome, unilateral renal parenchyma, disease, hyperthyroidism, and hyperparathyroidism. Okay, let's keep going. Let's see next. Here we got evaluation of the pulsatile abdominal mass and breadth. Evaluation of pulsatile abdominal mass and breadth is abdominal ultrasound and computer tomography. Una masa en el abdomen. ¿Con qué se evalúa? Se evalúa con tomografía y con ultrasonido. Seguimos. Perdón, esto es muy informal. Esto es para recordar. Summary. Indication of surgical correction of abdominal aortic aneurysma is un aneurysma that is bigger than 5.5 centimeter, rapidly increasing, enlarging, symptomatic or pulsatile or rupture. Remember, abdominal aortic rupture can give you low blood pressure, and tachycardia, and syncope, and things like that. It's a very real emergency, and you can die in less than 20 minutes. Indication for surgical correction of abdominal aortic aneurysm is an aneurysm more than 5.5 centimeter and rapidly enlarging and symptomatic or rupture. Forma de recordar, something to remember is 5.5 centimeters, more than 5. That means that you're gonna die in 5 minutes, less than 5 minutes. Treatment for acute coronary syndrome is in my country when I used to study medicine. It was morphine, oxygen, nitrogeno, and aspirin. In this case, in the United States, is aspirin, heparin, clopidogrel, morphine, sublingual nitroglycerin, IV beta blockers. Keep going. Let's keep going. So, treatment for acute coronary syndrome: aspirin, heparin, clopidogrel, morphine, oxygen, sublingual nitroglycerin, IV drugs, and beta blockers. Metabolic syndrome is an abdominal obesity, high triglyceride, low HDL, hypertension, insulin resistance, prothrombotic or pre-inflammatory states. Prothrombotic or pro-inflammatory states. Insulin resistance. Remember, when we got insulin resistance, you got that color in your skin, on your neck, and the back of your neck, that like a brown. They always asking that question. Appropriate diagnostic test. 50 years old man with a stable angina can exercise to 85% of the maximum predictable heart rate. So, exercise stress treatment with EKG. Exercise stress treadmill with EKG. I don't know what they're telling me here. Appropriate diagnostic test. Okay, the person can walk and have a stable angina, can exercise to 85% of the maximum predictable heart rate. So you can do that EKG with exercise. With the patient with 65 years old man, woman with the left bundle branch block and severe osteoarthritis has unstable angina. So that you do different things. You do pharmacology stress test. For example, you put dobutamine and do the echocardiogram. So in this case, they telling you what kind of diagnosis is better. So for a person that can walk and can exercise but they have an angina, you can do that exercise stress treatment with the EKG. A patient that cannot walk and have a blocker and things like that, you can have to do the pharmacological stress test. By example, dobutamine and echocardiogram. Okay, sign of active ischemia during stress testing. Sign of active ischemia during stress testing: angina or ST segment change, or EKG, or diminution of the blood pressure. So the doctor, cardiologist, is doing a stress test, and his patients suddenly start doing chest pain or ST segment change or blood pressure. They send it to the ER right away. EKG finding suggestion of myocardial infarct is ST segment elevation or depression, mean ischemia. Flatline T wave and Q waves. Q wave usually is all, like all MI. Could be acute, but can give you same sign of all. Coronary transitories in May high.